Okay, so our next presenter is Julia Lorence, who is presenting on improving culturally competent care of refugee expectant mothers in Maricopa County.
Hello, my name is Julia Lorence. I'm one of our clinic's adjunct research associates, and I have the privilege of representing the Valleywise Center for Refugee and Global Health today. I'm so thrilled to be here and share with you our research concerning both our refugee expectant mothers and our monthly maternal health education class, as we strive to both understand our community's needs and to improve culturally competent care for our patients. I have no relevant disclosures.
Hello, I'm Jeanne Nizigimana, currently the manager for the Center for Refugee and Global Health at Valleywise Health. Valleywise Health provides exceptional care without exception, every patient, every time. It is in that spirit that the refugee health services exist, with the mission to provide culturally, linguistically accessible, compassionate, equitable, and coordinated quality comprehensive health services to the refugee and immigrant families in Maricopa County in order to help them achieve equity. Let's talk about our cultural health navigation model. Looking at health equity, we are not only addressing language justice, culture justice, health equity, but we thrive to provide quality, accessible care through these 5 C's integrated care model. Of course, cultural health navigation, ensuring that they know where they are going, they know who to contact, and they have a trusted member for when they have any question. Communication to promote health. They are provided empowerment tools that are adapted in order to help them be self-reliant. Care coordination. Intensive case management ensures that every referrals, whether it's within or outside, is coordinated, and cultural health navigator is present to escort them wherever they need to go. Community partnered engagement. Cultural health navigators are part of the communities they are from themselves. These are members that are living with them. They shared lived experience. Capacity building. We're part of the communities, so we thrive in making sure they have the knowledge and skills necessary to help their own fellows to understand what is needed for them to change their health-seeking behaviors. We pair with mobilizers. Now I pass the rest to Julia.
Thank you, John. Addressing adverse maternal health outcomes is a pressing public health issue in the United States that requires urgent mitigation. Compared to other high-income countries, the U.S. has continued to exceed maternal mortality rates at an alarming pace, with disproportional impact on women of color who are at greater risk of adverse obstetric outcomes and whose mortality rate is 3 times higher in contrast to that of white women. Resettled refugees communities in the United States also fall into a high-risk group, facing additional challenges when navigating the U.S. healthcare delivery system, which can be particularly difficult during pregnancy. Community-embedded prenatal education and health services provide pregnant mothers with knowledge and resources that positively influence birth and maternal health outcomes. And thus our team developed a monthly Expectant Mothers class. While I was not present at its inception in 2013, I can comfortably say that the purpose of the monthly classes was and still is to deliver culturally informed health education surrounding topics that you see depicted on this slide. As our new hospital is opening, we are modifying our curricula and also have added pieces on both exercise and nutrition, which have proven to be interactive and rather entertaining for our moms. In conjunction with the car seat portion of our class, our patients each receive a car seat as well as other baby necessities as incentives for attending the class. Since being granted IRB approval in 2013, the classes have been held on a monthly basis, with the exception of a pause during the COVID pandemic, and classes were resumed in summer 2022. Initially, the purpose was to teach refugee mothers the importance of identifying signs and symptoms of labor, calling an ambulance early to ensure delivery will be at Valleywise with trusted and familiar staff, And our staff also asked how we can promote self-efficacy, with self-efficacy being defined as the ability to both make and execute plans independently. It's also important to note that our team has worked hard to co-create safe spaces for our women here, where questions and concerns are welcome and where our patients can put their trust in the cultural health navigators and use each other as resources. And it's been truly something special to be part of. These were our research hypotheses for the study. We hypothesized that attendees of the health education class would demonstrate increased knowledge, self-efficacy, autonomy, and high satisfaction with their birth experience due to heightened preparedness. We also hypothesized that they would be able to create and keep their birth plans. And lastly, we hypothesized that cultural health navigation positively influences birth outcomes. To test our hypotheses, we implemented the following research methods. Pre-interventional surveys were administered before the curriculum was presented in order to measure prior knowledge and to survey any existing labor and delivery plans. The class curriculum was then presented by medical students from different medical schools. This curriculum has been specifically designed to address common challenges faced by new and expecting refugee mothers. Patients were then given time to ask additional questions about topics covered during class, as well as speak to CHNs about any additional questions or concerns. Participants then were asked to complete a post-survey to measure self-reported knowledge gained to see if their labor and delivery plans had changed given the information that was presented. It's important to note that while the classes touched on many topics for the purpose of the study, the data that was analyzed just focused on labor and delivery and emergency planning portions of the class. A follow-up interview post-delivery was conducted by our cultural health navigators, and a retrospective chart review captured data related to birth outcomes. In total, we included expectant refugee moms that were seen at Valleywise Health and participated in the class and also received cultural health navigation. And then we also had a control cohort that was depicted of moms who were unable to attend the class because it was paused during the COVID pandemic, but still received cultural health navigation. Before I go over some of our study's preliminary findings, I would like to briefly go over the demographics of our sample, which is illustrated here. In total, patients from 38 different countries speaking 26 different languages participated in our classes over the year. Their average length in the United States was 35.4 months, or almost 3 years. And our top 10 languages and top 10 countries are depicted here. These demographics almost nearly mirror the overall demographics of patients served at the Valleywise Center for Refugee and Global Health, with the top 5 countries being Burma, Iraq, the Democratic Republic of Congo, Somalia, and Burundi, and the top 5 languages spoken being Arabic, Swahili, Burmese, Somali, and Kirundi. Of our patients, 27.7% were first-time mothers, while 72.3% had been pregnant prior to the study. Of the 72% who had children before, 54.6% delivered previously in their home country before relocating to Maricopa County. As part of our pre- and post surveys, we asked our patients if they knew how to get to the hospital, if they plan on delivering at Valleywise Health, if they were able to correctly identify 3 or more of the 4 signs of labor, the appropriate time to call for an ambulance, if they own a phone, and if they know how to contact their cultural health navigator. One of the questions on the pre- and post test was identifying the signs of labor. Between pre- and post test, participants were able to identify 3 and more labor signs, significantly more in the post-test relatively to the pre-test. As far as transportation plans, we saw the most significant change with patients leaning away from taking ambulances and more patients choosing to take the car of a family member following class presentations. And we also noticed a significant change among our patients in gaining more autonomy by understanding and knowing how to contact their CHNs and create birth plans. Additionally, we examined retention rates of our 75 class cohorts, with retention being defined as continuing obstetric care following delivery. We predict that cultural health navigation plays a vital and significant role in the retention of our patients. However, we were not able to identify a strong correlation between retention of patients and ability to contact their CHNs. Assessing birth outcomes, our team is proud that our C-section rates across both cohorts have been lower than the US national average. And exploring APGAR scores and infant weight, we are happy to report that the average APGAR scores of 8 at 1 minute and 9 at 5 minutes and healthy birth weights above 2,500 grams. We would like to address a few problems we encountered that were not foreseen. First, measurements including satisfaction were self-reported, which may produce measurement bias. Second, there was a significant number of missing responses to pre- and post-survey questions, with numbers dwindling from the initial pre-survey numbers, creating room for potential bias. It is likely that language and cultural barriers hindered back and forth communication between the educators, staff, cultural health navigators, and participants in the education class. We also suspect that some of this may have stemmed from a lack of understanding of the pre and post survey format, as it may not be something that they have encountered before. To improve this and make the survey more intentional, our team is explaining to patients that the questions will be answered twice, and we also begin by printing the surveys on 2 separate sheets, which could prevent score augmentation from people going ahead. In conclusion, we believe in our goals of increasing patient knowledge along with helping achieve self-efficacy and high satisfaction during their birthing experience were accomplished. Beyond that, patients also expressed high satisfaction, with nearly 100% stating they would recommend the class to others in the community. Our high retention and high satisfaction rates support the Valleywise Center for Refugee and Global Health as a preferred provider for refugee women in Maricopa County. We would recommend other clinics serving refugee patients to institute a similar class in order to promote patient involvement, education, and independence. Thank you for listening to our presentation today. To improve maternal health outcomes, it takes a village. And with sincere gratitude, I would like to thank our incredible 19 cultural health navigators, study personnel, fellow co-authors who have worked on this project before me, and our esteemed faculty, Dr. Johnson Akbakwu, Jean Nisiki Yimana, and Dr. Alicia Willie.